A very good afternoon to you all. And before I begin, I would like to thank Dr. Reena Sethi for giving me this opportunity to talk about ZEPTO. ZEPTO, basically what it is a precision pulse capsulotomy device. So I'll be showing you a video, first going through the basics of how it works and a few interesting cases that we have to share with you. Can we have the video? Can we have the laptop connection, please? Yeah. All right. So this is the precision pulse capsulotomy system. And as we know, capsulorhexis is the most important step of cataract surgery. And therefore, we here share our experience with this device called ZEPTO, manufactured by the Minosis company. Now, first, it consists of a hand sole, which is a very small console, which can be placed in the OR directly, and comes with a console as well as a handpiece. Now, in this handpiece, there is a plunger system. We can make it go forward, and the plunger is connected to a suction cup, which houses a nitinol ring. So, when we push it forward, it takes an oblong shape and becomes narrower, and then we can pull it back. So, once we are inside the eye, we pull it back, retract it back so that it assumes a circular shape, and then we can go ahead with our capsulorhexis. So, let's shift to the microscopic view here, and we are looking at our first case. This goes in easily with a 2.2 millimeter incision. I like to stain the capsule with trypan blue before going ahead with this device and inject a dispersive OVD. Then we have made it oblong and inserted it inside the eye, and then we retract the push rod back so that it assumes a circular shape. Then we have to apply this suction cup onto the anterior lens capsule, and when we see the movement of these water molecules, that's when we press the button on the console, which releases this electrical discharge and gives us a nice central 5.2 millimeter capsulorhexis. Now let's look at a few interesting cases here. So this is a patient who has mature intermittent cataract. We like to use this device for such cases. And we see here that as soon as we apply the vacuum, the iris starts getting sucked into the suction cup. And the iris does not get damaged, but somehow it has gotten inside the cup. We come out of the eye, and then we decide to inject viscoelastic to really push the iris back and to look at the margin of the capsulorhexis here. And we notice that we have an intact capsulorhexis, so it has managed to cut through, and we can safely proceed with phacoemulsification here. Then our third case is that again of a white intumescent mature cataract, and this patient has been planned for a toric IOL. So we try to put our device to the test in such cases, and what we see here is that we have had a part of the capsule which remains uncut. So we've had skip areas here, probably because of inadequate contact between the suction cup and the anterior lens capsule in this particular case. So we are using a combination of the rhexis forceps as well as scissors to take care of this tag so that we can proceed safely further. Our next case here is just a grade 2 cataract, and we are using the ZEPTO device in this patient. And once we have made the capsulotomy, we see that we have a nice intact capsule. But notice here carefully that as soon as we inject the fluid, as soon as the hydrodissection is initiated, there is an anterior capsular tear. Now this could be maybe because the bag was inflated once we released the vacuum and the fluid had been pushed into the bag. So it's a good tip to decompress a little. Now, fifth case here, the capsule is intact to begin with. We have had an intact capsulorhexis, but as soon as we start our chopping maneuvers, there is an anterior capsular tear during chopping. Even though the chopper has not hit the anterior capsular margin, just with the shearing forces, somehow the capsule has torn. And this is very interesting and rare, as we know that this device actually gives us a stronger rhexis than manual. Now, this is a patient who was on an RK surgery about 20 years ago, and now he has this calcified capsule and a small pupil. So we know calcified capsule is very difficult to tackle just with a manual rhexis, so we decide to put this device to test over here. And what we notice is that even though this device cuts the capsule on top, but it is unable to cleave through this fibrotic area. So we are just using a combination of micro scissors and micro forceps to take care of this fibrotic part of the capsule. and then proceed with the surgery after inserting the malucin ring to take care of the small pupil. We insert the IOL in the eye, and then we are further trimming down this fibrotic plaque once we have safely done the surgery and inserted the IOL in the bag. So we have learned from this case now, and we have proposed with another case here with a similar case where we have this kind of a calcified capsule. So what we do here is we modify our technique and we plan an eccentric capsulorhexis, an intentionally eccentric capsulorhexis, so that all of this capsule which is calcified comes within the suction cup, so that it cleaves throughout, and we are able to achieve a good rhexis here. So we can see that we did not have to cut through with the micro scissors or micro forceps in this particular case, and we could safely go ahead with the phacoemulsification part of it. This is the IOL in place, of course a little eccentric but safer. Now we have this intumescent white cataract, and as we use this device very frequently in intumescent cataracts because to avoid this Argentinian flag sign, and we've actually had this issue that I'm going to demonstrate here in 2 patients. So what happens here is that we are unable to release the suction. So we have cut the capsule and we are pressing the suction continuously on the console, but somehow the capsule has gotten stuck to the lens and we are unable to release it. And the other case also in which we experienced this was again an intumescent cataract. So probably because of the fluid present, it sort of just gets sucked in. So finally I had to take my dumbbell dialer underneath this capsule to release the suction, and then we could pull this device out of the eye. And then the rest of the case proceeded as routine. Now this patient, what happens here is that as soon as we apply the suction, the anterior capsule gives away. So this is again an intumescent cataract, a lot of fluid inside, and although this tearing is limited within, but as soon as we start withdrawing the probe, we can see that it further tears, and there we've had a runaway rhexis, almost not completely like an Argentinian flag sign, but on one side it has run away. And we notice that the posterior capsule is intact, there is no posterior capsular extension, and we can complete the case with ease. So here are just a few salient points that we would like to share, the experience that we have had with this device. To conclude, this system is specially safe and gives us a precise capsulotomy, useful for premium IOL surgeries, intumescent cataracts, patients with corneal opacities, small pupils, and even calcified cataracts. So it comes in handy for all of these cases. We need to understand that we can still have complications, and we need to be mentally prepared for these, including a complete capsulorhexis or even anterior capsular tears while using this device. A few of the important points is that sometimes if the too much fluid gushes out, we can have an overinflation of the bag, although this is very rare. So one of the cases that I demonstrated had an anterior capsular tear, so maybe just gentle hydrodissection or decompression would come in handy. Intumescent cataracts, we might have very rarely cases like this where we have difficulty in releasing vacuum, or we might still encounter a runaway rhexis, not probably like an Argentinian flag sign. So thank you so much for your attention. Thank you, ma'am, for inviting me to this course.
Thank you very much, Dr. Agita. Now, to have a little conversation on this, a little debate, do you do flax as well?
Ma'am, we don't have flax in our center, so yes, I'm not very well versed with flax.
So with flax, people, they earlier on they were thinking of the lines of that, it's not a very strong rhexis that you have.
Yes.
But then since it's been devised and better technology has come in, so still, if we have to compare, what would your take-home message will be like? Would you rely more on the ZEPTO or yeah?
So flax is the problem with flax is to have a separate operating room to maintain the temperature and the humidity profile. We can't keep it in the OR, that's one. The expense that it adds to your surgical cost is huge, and the further expense to the patients. Secondly, the capsulorhexis that it creates is not as strong actually as the ZEPTO capsulorhexis, and this has been demonstrated in various animal models that this rhexis is actually 4 to 5 times stronger and has more shear forces that are required to actually rupture it than a rhexis that is created with flax. The advantage that flax would probably have is that it can also help you a little bit with the nucleus management, which the ZEPTO device currently cannot do.
Absolutely.
So that would be my take on it, ma'am.
And this would be one. And exactly like, what about subluxated lenses? Do you think...
Yeah. So it does work in subluxated lenses. I have used it in 2 patients, but not with gross subluxations, maybe less 3 clock hours, because you do not want to put in so much of a vacuum when you have a grossly subluxated IOL, because just with the sheer vacuum you might disturb the lens nodules further. And it seems to work well. Even flax seems to work well in subluxated cataracts. Yeah. So I'm not sure. I don't know if we have the comparison enough cases to compare flax versus ZEPTO in subluxated cataracts. But both seem to work well, because it's difficult to do a manual rexis when the lens is subluxated.
Thank you very much. Thank you. Any questions, Shikha?
So, how do you've compared it with flax? How do you compare it with your routine manual capsular rexis?
Yes, ma'am. So, quite frankly, just to share my opinion here. If you have a routine case where there is no intumescence, it's not a patient with a corneal opacity or a fibrotic capsule, I feel for routine cases, manual rexis in experienced hands, of course, works as well as flax, as well as precision pulse capsulotomy device. I do feel that for routine cases, all the techniques work very well, and there are studies published on it as well. There are comparison studies which are published, and it has been shown that the centration of the IOL and all these parameters are very comparable with all these 3 techniques. I think it comes in handy only for these couple of cases that I demonstrated, for intumescent cataracts, for calcified capsules, maybe even for small pupils. Small pupils, now we have excellent pupil expanding devices, which we can use and then proceed normally with the rexis.
So you've shown quite a number of videos. You seem to have quite a bit of experience. See, anything at which you've worked at, you've done repeatedly, is bound to give results.
Yes,
and you seem to have worked with this device in complicated cases quite a bit. And you personally feel that it gives you better results than what you would have done manually if you didn't have this device. Just want your opinion.
Just for like I said, just the cases that we have highlighted, like if you want to implant a premium IOL in a patient with an intumescent cataract, if you're going for a multifocal or a toric in such complicated cases with a fibrotic capsule, then I think it's a nice tool to have. But of course, there's nothing that can replace the surgical skill that you have. You can still do a wonderful capsular rexis.
I'm asking you. You've used this device.
Yes.
And if you're going to plan a premium IOL and there's a little bit of complication, you're going to go with this.
Yes,
you're going to trust it.
Yes,
I want your opinion since you've used it.
Yes, absolutely. If I have a white intumescent cataract and I'm planning like a multifocal IOL, absolutely. I tell my patients, we in fact have a counseling protocol at our place that if we have a intumescent cataract, they are informed that it is a better technique for you, and I would definitely go ahead with it. I trust the device. It works really well. The cases that I've shown are not the routine cases. These are one-off cases that we have collected over a period of years. And so we have had these kind of issues and complications, and I just wanted to demonstrate that. But 95% of the times the case goes on very smoothly and there is no issue whatsoever with the device.
Thank you so much. Thanks.